on this case.
But to my understanding, what is the then after the management is over, but I would like to know what is the cause of because as somebody said that COPD, but history is not very clear about the COPD. That is one issue. And then in X-ray and CT, I am seeing that there is a bilateral effusion and there is a precardial effusion. Also, I understand. So, if INC is very obese, I think 35 is the BMI, and whether obstructive sleep apnea was also associated with that, that has to be, ultimately when the emergency and everything you are managed, probably we have to go on these things to find out what actually has caused this. It's simply a respiratory or cardiac failure or some definite diagnosis, something definite in the body is going to lead to all these formations. Fluid, I'm not sure whether it was transudate or exudate.
So transudate.
Transudate, so definitely it is focusing that cardiac element is definitely there. And pericardial effusion was tapped.
Yes, yes, sir.
It was also transudate.
Yes, sir.
It was also transudate. So what is the combination? So there is a combination of lungs and heart. And what was the GBP? Whether she also has part pulmonale, swelling of feet were there.
Yes, sir.
The might be. So all this is culminated, but what I am not able to understand, what would be the ultimately you have to diagnose what these things are causing. That is my, otherwise every aspect of the acute management has been very well discussed like this.
I think there are multiple challenges because once you pass the first day in the ED or in the next day in the ICU, there will be a lot of things being done for this patient, including lines, including procedures, including ultrasonography, including repeated nebulizations, IV steroid, short course of antibiotics based on your antibiogram of your local hospital or whatever, and a short course of antibiotic will definitely be there. Heparin, as was told by sir, low molecular weight heparin will definitely be there. She's already on aspirin with NST segment changes which are there, so that will definitely be there. But as the time goes, what sir is asking is, say she stays there for another 5-7 days, what is finally going to happen? Now, since there are diabetic element, there are hypertensive element, then there is a COPD element, then there is hypothyroidism as well. So I think I'll deal with each of them. Ultimately, this patient will go with polypharmacy. But at the heart of everything here starts is an acute exacerbation of a COPD. Probably she was non-compliant and therefore she's like this. There was an underlying element of the heart in terms of hypertension and diabetes, like a syndrome X presentation, which has got multiple features into this, and therefore she is physiologically decapacitated patient who has landed in your emergency. So with time, I think a lot of things have to be done for this patient. And it will not be a single diagnosis, it will be a huge physiological diagnosis.
I just want to add one more thing that Dr. Swapnil has already highlighted that this patient has a past history of myocardial infarction and the ECG was not completely normal. There is a loss of R-wave from V1 to V4. There is a widening of little of a QRS, which suggests that probably I was not very well versed with the echo finding of this patient, saying that the patient, there is no resting regional wall motion abnormality and the patient doesn't have the normal ejection fraction. This doesn't goes with the ECG, which looks like there's a widening of QRS. Patient has a past history of myocardial infarction. They will be less likely to have a normal. This ECG is not normal. You see, there's a loss of R wave. There's no progression of R wave from V1 to V2, V3, V4, which is called as a pseudo myocardial infarction pattern. This is commonly seen with COPD patients as well, and Q wave like things in 2-3 AVF. It may mimic like a COPD as well, but we need to know about the ejection fraction. And as this patient has a past history of myocardial infarction, and raised troponins and CKMB. Once the patient gets stabilized, we will just like to see the patient's coronary angiogram, and we will like to know what is the coronary anatomy in this case. And proper management of patients' thyroid function is also required. The cause of pericardial effusion is possibly because of uncontrolled hypothyroidism.
Thank you, sir. Dr. J.K. Mishra, sir, please comment on this case.
Thank you, Dr. Pathak. I congratulate Dr. Swapnil for this excellent case presentation. It is a real case presentation which we need in such type of gatherings. Second point is that Dr. Singh, Dr. Pathak, Dr. Pandey and our teacher, Dr. Rajendra Prasad, sir has told each and every point about the case. What I want to say, that most important point which we should take from this discussion is the bedside practice. The learning and the knowledge and the facility of bedside ultrasound in the diagnosis and management. So big, so accurate, nothing can be better than this. Another point is that each and everything has been discussed. It looks very simple in the discussion, but I can guarantee that it is very difficult to manage this patient, and nobody can guess what will be the prognosis of this patient. It is a multi-organ system failure. No one person can manage this patient. We need all these specialists: diabetes, cardiology, chest physician. She may go in renal failure and she will go differently. Definitely, if you keep this patient in the ICU, there will be hospital-acquired infection. There is 100% guarantee that if we put this patient on the ventilator, she will be infected hospital. Therefore, it is a very excellent. I congratulate Dr. Pathak as well as Dr. Swapnil, and I have great thanks for all my panelists. They are all my seniors. They are excellent people in their fields. And Dr. Rajendra Prasad sir is our teacher, great teacher. And I am fortunate. I am very, very much thankful from the core of my heart for inviting me here and for giving me opportunity to accompany such type of excellent clinicians at the system. Thank you so much. Thank you so much.
Thank you, sir. Thank you, sir.